Hey guys, welcome back to my channel, The ENT Resident. Today we'll be discussing about endonasal rhinoplasty, also known as closed rhinoplasty. We'll talk about what is it exactly, what is the approach here, what are its indications, what is the procedure. We'll be discussing in details about the steps of the procedure, and we'll talk about the advantages and disadvantages of this approach to rhinoplasty. You can also now purchase my notes. I have added links in the description. Okay, so let's get started. So, closed rhinoplasty or endonasal rhinoplasty, as the name is suggesting itself, this is an approach to rhinoplasty where all the incisions that we are placing are being placed entirely within the nasal cavity and with no external skin incision. So, this is a closed approach towards rhinoplasty, and the other type of rhinoplasty here is the external or the open rhinoplasty, where we give an external transcolumnar skin incision to enter the nose. So here all the incisions will be placed entirely within the nasal cavity and we'll have no external skin incision given here. Now, what are some indications of performing a closed rhinoplasty? So, closed rhinoplasty, because it is all the incisions are given within the nostrils, it is actually very limited in its approach. So, our indications are a very few over here. So, in case of dorsal hump reduction or mild to moderate tip refinement surgeries, if there is a complex tip deformity involved where there's a lot of work needed, then the external approach would be better fitted for these cases. Then, in case of alar base reduction, or in cases of narrowing a wide bony pyramid, and also if the patient shows a preference towards having no external scar. These are some indications for which closed rhinoplasty or endonasal rhinoplasty is preferred. Now let's try to understand. Before we start our approach, we'll start with anesthesia and we'll discuss the position of the patient first. Now coming to anesthesia, we can perform the surgery either under local anesthesia or under general anesthesia. Now general anesthesia, we try to reserve it for mostly very extremely apprehensive patients. And if we do indeed use general anesthesia, in that case, we'll prefer to use hypotensive anesthesia, as that will reduce the chances of bleeding during the time of operation. And in this hypotensive anesthesia, we try to lower the systolic BP to about 70 to 80 millimeter of mercury. Only then can you expect minimum or no bleeding in these cases. So that's about general anesthesia if we were to go for it. Now, most of the cases can be done under local anesthesia. Now, why is local anesthesia much more preferred? First of all, it is comparatively safer and the bleeding is way lesser. So, advantages of using local anesthesia would involve that you can first of all use adrenaline, so it does permit a much drier field. Second is there's saving of anesthesia cost and manpower involved as well if you use general anesthesia. So all of the cost saving can be done in case of local anesthesia. And also the patients have less post-operative discomfort in case of local anesthesia. So, if you're thinking of taking up your rhinoplasty case with local anesthesia, in that case, we also use certain pre medications. So, we use two things over here. First is we use a combination of a 30 milligram of Fortwin and 25 milligram of Phenargan given intramuscularly. Or instead of Phenargan, you can even give diazepam 10 mg intramuscularly. And this is usually given about 1 hour before you perform the surgery. Now, what is the purpose of giving this pre-medication? The purpose being we are relieving the patient from anxiety and apprehension. And if your patient is extremely anxious, that will not work out for you. In that case, even sometimes we consider giving a continuous sedation with intravenous midazolam through the IV saline drip. So that's about the local anesthesia part. Now, next is whether you do local or general, we have to give some infiltrations as well. Now, what infiltration are we giving and what are the sites of these infiltration? This is very important because we are going to be working all around the external nose area. So anesthesia of the external nose, we are achieving it by blocking the nerves which supply the external nose and by infiltration in the subcutaneous plates. Now, what is the agent used over here? We are using 2% lignocaine added with 1 is to 1000 epinephrine to produce between a concentration of about 1 is to 50,000 to 1 is to 1 is to 1 lakh strength of epinephrine. This is the usual dosage that we use for infiltration anesthesia. And after you have given the infiltration anesthesia, you should wait for at least 10 to 15 minutes for the action of the vasoconstrictor to have its maximum effect. This delay that you give will actually help in even your patient calming down and relaxing, and also it will give the drug for its action to work. So if you give infiltration anesthesia and immediately get started, you may not get the vasoconstrictor effect that you thought you would. So waiting 10 to 15 minutes after giving the infiltration anesthesia is a very good idea. Now next, let's talk about what are the sites at which you will be infiltrating the external nose. First of all, if we look at the image over here, let's look at the image. This is the image showing the external nose nerve supply. First of all, we have the infraorbital nerve. Here we are seeing the infraorbital foramen and the nerve exiting from the infraorbital foramen. So here what we do is we insert the needle about 1 centimeter lateral to the alar margin. If you look at the image here, this is the alar margin. 1 centimeter lateral to the alar margin is where we insert the needle, and this is given at a line below the pupil. Now the needle needs to be angled superiorly so that we strike the bone when we insert it just below the infraorbital margin. And this you should be able to palpate in the region by palpating with your left hand finger. It is not necessary that you hit the nerve with the needle directly in the infraorbital foramen. Just being in the general area is enough. So this is our first site in the infraorbital nerve, which is given 1 centimeter lateral to the alar margin. Second is, we also have some nasal branches of this infraorbital nerve. These can be blocked by inserting the needle inside the nasal cavity and in the lateral wall of the vestibule near the piriform crest, and will deposit some drug in the vicinity of this region. So that will take care of the nasal branches of the infraorbital nerve. Next is we have the base of the columella. So this is a columella region, right? So the base of the columella, here we will infiltrate by inserting the needle at the alar base from the right side to the left side. And about 1 cc solution is given over here while you're withdrawing the needle. What are the nerves getting blocked here? The nerves getting blocked here are some peripheral twigs of the palatine nerves which supply this base of the columella region. So this is our second region of infiltration. Our third region would be the dorsum of the nose. So this is our dorsum of the nose. So what do we do here? In the dorsum of the nose, we'll anesthetize by passing the needle between the upper lateral and the lower lateral cartilage. So we know here is the upper lateral cartilage, here is the lower lateral cartilage. We'll pass the needle in between the two cartilages through the nasal cavity. So this is given intranasally. So we pass the needle through the nasal cavity in between the upper lateral and the lower lateral cartilage. And the needle is inserted keeping its bevel towards the skin. And as you insert, we'll slowly withdraw and keep reinserting it in different directions and leaving lignocaine solution everywhere. Now, what are the nerves getting blocked here? If you look at the image here, we have the infratrochlear nerve, and we also have the external nasal nerve. This is our external nasal nerve. These two nerves get blocked by deposition between the medial canthus and the nasion. And when you give your injection in between the medial canthus and the nasion, it takes care of the infratrochlear nerve fibers. And when you give at the level of lower border of the nose for the external nasal nerves. So that's about this. And lastly, we give a little bit of infiltration in the membranous septum region where we are going to later put the transfixian incision. We have spoken about transfixian incision earlier in our rhinoplasty incisions video. You can check it out over there to understand what is the transfixian incision. So all in all, these are all the infiltration regions that we have over here. So if we had to summarize this whole thing, the regions involved over here are, first of all, we are anesthetizing the infraorbital nerve, then we are anesthetizing the nasal branches of the infraorbital nerve, then we are giving in the base of the columella region for the peripheral twigs of the palatine nerves, then we have the dorsum of the nerve where we are anesthetizing the external nasal nerve and the infratrochlear nerve, and lastly we give some in the membranous septum region as well, where we are going to give the transfixian incision. So this is all about anesthesia before we start our procedure. Next, we are going to talk about how are we going to position the patient. This is very important. We'll make the patient lie down in a supine position and we'll elevate their head end by about 20 degree. Now, what is the reason for elevating the head end? Raising the head and the trunk, what it does is it causes a slight postural hypotension and the bleeding reduces during the time of surgery. So this is how we are going to position the patient. Now, in a case of rhinoplasty, it is also very important to have very good lighting in your operating theater. So we need two types of light over here. One light will be focused on, if this is the patient lying head end over here, we need one light which will be focused on the face and the nose from the top, and one light which will be projecting from the foot end of the patient inside the nose so that a nose is illuminated well. So it is very important that proper lighting is there when you are performing rhinoplasty. Next, after you have positioned the patient, we'll do some basic dressing and draping. We will be preparing the forehead, the nose, the face of the patient by with some antiseptic lotion, whatever is used. Maybe you can use betadine. And then we will perform draping. The towels are draped such that the forehead and the entire face remains exposed, and the lips are covered with a wet gauze to prevent any dryness of the lips. Before you start giving your incision and start the procedure, the nasal cavities should be repacked with some thin ribbon gauze which has been soaked in 4% lignocaine to supplement the topical anesthesia that has been given and to prevent any blood from seeping into the pharynx. So, this is about preparing our patient for surgery. Now that the patient is prepared, we are going to start our surgery. Now, before I start the surgery, now this can be a very difficult one to understand. I have tried to simplify it by breaking it down into easy steps. And also, I have shared a lot of images for you to be able to visualize the surgery as we discuss it. Now, before we start discussing each one of the steps, I'll first like to tell you the sequence that we will be going in. So, first of all, after we have positioned the patient, we will be giving opening incisions. After you have given incisions, we will mobilize the skin. Next, we will elevate the periosteum. Next is we will be managing the upper lateral cartilage. After management of the upper lateral cartilage issues have been done, then we will remove any hump if present. If you need to do septoplasty for the particular case, in that case, this is the right time to do the septoplasty. We usually do the septoplasty after hump removal has been done. If septoplasty is done, we have finished it. Next, we move on to narrowing of the nose. And here we do narrowing of the nose by performing certain osteotomies. After narrowing of nose is done, so first we have taken care of the width of the nose, then we will shorten the nose. Next, we have correction of the septolabial webbing and lengthening of the upper lip. Lastly, we'll take care of the tip region, and after the tip region has been taken care of, we'll close the incisions, pack the nose, fix the skin, and splint the nose. So this is in short a sequence that we will be following in today's discussion. So our first step over here is going to be opening incisions. So what are we going to do here? First of all, we'll take an alar retractor and then we'll retract the alar with the help of the alar retractor like this. so that the inside of the nose is now exposed to you. What we are going to look at is, first we will look at the caudal edge of the upper lateral cartilage. Now here is where we will be giving our incision, which is the intercartilaginous incision. To know more about the incisions in details, I already have a separate video on rhinoplasty incisions. You can check it out over there. So intercartilaginous incision, which is also known as Lyman vestibuli incision. This incision is given with the help of a 15 number blade, and the site of the incision is on the caudal edge of the upper lateral cartilage. So we will start just above the scroll area and we'll extend towards the septum near the weak triangle and then towards the anterior septal triangle. After giving the incision, we are going to incise the mucous membrane, which is joining the upper as well as the lower lateral cartilages. Now, incision has to be long enough so that you're getting adequate exposure of the dorsum of the nose. So that's something that you need to look at. Now, once the incision has been completed, our next step over here would be to undermine the skin over the dorsum. So we'll slide the blade, as you can see in the image over here, between the upper lateral cartilage and the skin, upper lateral cartilage and the skin which lies on top of it, and we'll try to undermine the skin, meaning we'll try to separate out the skin from the cartilage. And it is very essential that when you're inserting the blade over here, you keep the blade very close to the cartilage itself so that you do not injure the skin by any chance. So this will be our second step, where we are undermining the skin over the dorsum. After this, our next step would be to give the transfixian incision. So before we do that, there are particular steps to it. First of all, we'll make a hemi-transfixian incision on the left side. That is on one side. So we have given the hemi-transfixian incision on one side. Again, to learn more about hemi-transfixian incision, I already have a video on septoplasty incisions where I discuss it in details. You can check it out over there. So hemi-transfixian incision is the incision which is given at the caudal border of the septal cartilage. So here, this is what the hemi-transfixian incision will look like. Once you've given it on the left side, then we'll give hemi-transfixian incision on the right side as well. Before we make it through and through, where we are going to insert and connect both the incisions, we'll go from the right side to the left side. This conversion is what is known as a transfixian incision. So the transfixian incision is made just in front of the caudal edge of the septal cartilage, as you can see over here. We'll pass it through and through from the right side to the left side. From the left side to the right side. Now this transfixian incision in itself, you can either give a complete transfixian incision or you can give a partial transfixian incision. Complete is when you're giving it right down to the anterior nasal spine. Whereas partial incision is when you're only giving about till 1/3 of the membranous septum. Partial transfixian incision is given when you do not require any septal surgery. So you do not require any septal access. So we have made the transfixian incision now, and we'll have to make sure that we are avoiding cutting through the middle of the membranous septum, because that can actually lead to post-operative scar formation. So this is all about the incisions. Eventually, after you finished it, this is what it will look like. If you look at this dotted line over here, this is the intercartilaginous incision, and this is the transfixian incision. So this is what our opening incisions is going to look like. So we have given the intercartilaginous incision, then we have undermined the skin over the dorsum, then we have given hemi-transfixian incision on the left side followed by the right side before making it through and through to convert it into a transfixian incision, and we'll decide depending on the exposure needed whether we'll give a complete transfixian or a partial transfixian incision. Now, moving on to our next step, we have mobilizing of the skin. So once incisions have been given, our next step would be to undermine the skin. This we can either do with the help of a number 15 blade or we can use a blunt-ended medicine-bound scissor. Here, we are going to undermine the skin on the sides of the dorsum only to the extent that is required. Usually, we do it from the roof of the nose to the supratip area. Now, it is important to remember the extent of the undermining of skin that you will be doing. You should avoid too much of lateral undermining of skin, especially over the site where you're going to give your lateral osteotomy, because in this region where you're going to be placing the lateral osteotomy incisions, the intact skin needs to be remain between the proposed lateral osteotomy site and the rest of the undermined nasal skin, so that the osteotomized bony parts get enough nourishment from the region. So we will not go too laterally over the site where we are thinking of giving the lateral osteotomy incision. And it is also important that the undermining of skin that you do is symmetrical on both the sides. Another thing to remember is that we are going to not undermine the skin over the glabella. We are going to avoid doing that. And when you come across the procerus muscle in this region, when you come across the procerus muscle, we are going to separate it out from the skin using the scissors. And another thing to remember, these are all cautious points to remember while you're doing the surgery, that you should not undermine the skin. You should try to undermine the skin very close to the osteocartilaginous framework, so that you are minimizing the bleeding and you do not damage any blood vessels or any muscles which is situated superficially in the skin. So we'll try to remain close to the osteocartilaginous framework of the nose. And in case there is a history of a previous trauma, or if it's a very revision case being taken, we are going to be expecting a lot of scar formation in these cases. So in those cases, using the scissors is preferred over the number 15 blade. So that's about our second step, which is mobilization of the skin, where after giving the incisions, you are separating out or undermining the skin with the help of a scissors or a blade. And we'll remember the extent would be from the root of the nose to the supratip area. And the things to keep in mind is we will not undermine the skin in the glabellar region. We will make sure the undermining is symmetrical on both the sides. We will not go undermining the skin in the lateral osteotomy site. And we will remain very close to the osteocartilaginous structures so as to minimize bleeding and damage. Next, we move on to our third step, which is elevation of the periosteum. Now, what are we going to do here? Here, the instrument that we are going to use is Cottle's nasal periosteal elevator. So, first of all, what you'll do is you'll try to palpate the lower edge of the nasal bone. If we look at the image here, this is the nasal bone. We will palpate the lower edge of the nasal bone over here. Then we are going to incise the periosteum with the tip of this Cottle's elevator, periosteal elevator, just above the lower edge of the nasal bone. This is where going to incise the periosteum, and this is a very sharp instrument. So here we'll incise the periosteum along the lower edge of the nasal bone. After you have given the incision, the next step would be to undermine the periosteum, meaning we are separating it out. So undermining of the periosteum has to be started laterally with firm pressure using the index finger of your left hand. And the same instrument that we have used to give the incision, we are going to pass it between the periosteum and the nasal bone, and we'll try to separate out the periosteum from one side, then go over to the dorsum, and then move on to the other side. So we'll start from one side, move over the dorsum and go towards the other side. So we have undermined the periosteum. Next would be to elevate the periosteum with the help of very simple gentle movements, and we'll make sure to be careful not to end up in perforating the periosteal layer. So you have to be very careful with the movement of the instrument, because if the instrument slips underneath the nasal bone, you can actually end up dislocating the upper lateral cartilage. If you remember the video where I spoke about the surgical anatomy of the nose in relation to rhinoplasty, where I said the cephalic border of the upper lateral cartilage actually lies underneath the nasal bones. So if your instrument slips through, it can actually end up dislocating this cephalic end of the upper lateral cartilage. So we'll elevate the periosteum with very gentle movements, and we'll avoid making any perforation in the periosteal layer. In case there is a very big hump, dorsal hump, in that case, usually we undermine the skin and the periosteum separately. But in all other situations, usually undermining of skin uh, is done up to the lower border of the nasal bones, and then beyond that the skin and periosteum are undermined together as a single layer. So this is what elevating will look like as you move the instrument from side to side, trying to elevate the periosteum. So this is our third step, which is elevation of the periosteum. After we have elevated the periosteum, our next step would be to take care of the upper lateral cartilage. So what are we going to do here? So we will first of all assess the scroll of the upper lateral cartilage. To know what is the scroll, again refer to my surgical anatomy video where I explain more about it. So once you have assessed the scroll of the upper lateral cartilage, in case it is very prominent, in that case you may need to excise the scroll. And here you have to be very careful that excessive connective subcutaneous tissue, if it is present on the lateral surface of the upper lateral cartilage, that will also need to be excised over here. Then we will going to incise the upper lateral cartilage from its junction with the septum. So upper lateral cartilage goes like here, and in the middle is the septum, and the junction at which it gets attached over there, we will be incising it with the help of an angled Fomon scissors on both the sides. And the upper lateral cartilage should be divided very close to the septal cartilage, so that here, if you look at the image over here, we will be doing it very close to the septal cartilage, so that no part of the upper lateral cartilage remains attached to the septal cartilage. And then once you have severed the upper lateral cartilage along with its underlying mucosa, we our next step is done. So here usually what we prefer is a submucous severance, because that will help us in preserving the mucosal integrity of the internal nasal valve function. Now, so you have you have severed the upper lateral cartilage from the septal cartilage attachment. Now, next what you will be doing is you will trim the excess portions of the upper lateral cartilage. If there are extra parts in the medial border of the upper lateral cartilage, we are going to excise that, and we'll excise any portion which is likely to project inside the nasal cavity. But you also have to remember that we should not perform over resection of the cartilage over here, because if you end up excising too much of the upper lateral cartilage, in that case, the nose can actually get this pinched nose appearance in the lower cartilaginous vault region, and the nose can actually end up becoming short post-operatively. So we have to be very careful about how much we are excising. We'll excise only the amount that is absolutely required. And another thing to remember here is, if we require any dorsal implants for augmentation purpose in our case, we then in that case upper lateral cartilage should not be detached. They should be kept intact so as to maintain the integrity of the cartilage with the septum, because that will help you in giving a stable bed for graft placement. So at this step, what have we done? After you have mobilized the skin and the periosteum, first we will assess the scroll of the upper lateral cartilage. Then we'll excise the scroll if it is too prominent. If there is excess subcutaneous tissue, we'll be excising that. Then we will be incising the upper lateral cartilage at its junction with the septum. And we'll try to stay as close to the septum as possible, so that no part of the upper lateral cartilage is attached to the septum. Next is then we will be trimming the upper lateral cartilage based on our requirement, but we have to be very careful that we do not end up over trimming the whole thing, because that can itself lead to a pinched nose appearance post-operatively. And in case we require, if your case needs augmentation with dorsal implant, in that case, we will not be detaching the upper lateral cartilage so that it is able to give a stable bed for graft placement. Next, moving on to our next step after we have done upper lateral cartilage management is a hump removal. Now, before we go into hump removal, first let's try to understand what are the different types of hump that we can come across. First of all, we can have a true hump or a pseudo hump. True hump is basically developmental in type, or it can be a racial feature as well. Pseudo hump is when the osteocartilaginous area becomes too prominent due to flattening or saddling effect of the lower cartilaginous vault as a result of either some kind of trauma or a radical submucous resection of the septum. So these are the two different types of hump that can be there. Now, secondly, depending on the location of the hump, we can either have the hump in the bony region only, or we can have a hump which is only in the cartilaginous region, or we can have a hump that involves both the cartilaginous as well as bony regions. So now that we know what a hump is and what areas it can involve, next we have to understand what are we going to assess for the hump removal. So the things that you will be assessing is, first of all, determine what is the level of the hump removal. So we'll determine the level of the hump removal. Usually the hump is removed above an imaginary line which is passing between the tip projection and the depth of the nasofrontal angle. This is your tip and this is your nasofrontal angle. So an imaginary line passing through this, anything that remains above it is going to be removed. So this is how we determine the level of the hump removal. Next is we also evaluate the chin. It is very important that you look at the chin, because sometimes how the chin looks like based on your hump removal and how much you deepen the nasofrontal angle and how much you shorten the nose, it can actually make a receding chin look less noticeable. And if in case the patient does have a receding chin, in that case that should be treated with the help of mentoplasty. So we have to first assess the chin and decide based on the presence of a receding chin, or whether there is too much of a chin exposure present over here. In that case, we will decide how much hump removal needs to be done to give a normal appearance to the patient. Next is, after we have done all this assessment, we are going to do hump removal. So now the first step would be, we have already decided how much hump removal we are going to do. So the extent of the hump to be removed has to be first marked with the help of gentian violet. That will help you in guiding for the hump removal. Then you are going to expose the dorsum of the nose and visualize it with the help of a nasal retractor. So if we have cartilaginous hump as well as bony hump, in that case, first we are going to take care of the cartilaginous hump, and then we are going to take care of the bony hump. So first is cartilaginous hump removal. Here we can either use a blade, number 15 blade, or we can use scissors as well. And here we should be removing it atraumatically, as if we cause trauma over here, it can delay the healing process and there can be excessive amount of connective tissue formation, which itself may end up rounding the dorsum. So you have to be very careful about doing the cartilaginous hump removal with the help of the blade. Like you see in the image over here, we introduce the blade intranasally over here, and we excise of the cartilaginous hump region. And we have to make sure that this is atraumatic. Next, after you have done the cartilaginous hump removal, then we move on to the bony hump. Now, what do we do here? So, cutting of the bony hump here, you can either use a saw, you can even use a chisel, you can use a rasp, or you can even use a bone forceps. You can use any one of these instruments to be removing the bony hump. So, first, let's talk about the saw. So if we were to use the saw, we are going to introduce the saw through the left nostril like you're seeing in this image, and we'll introduce it through the intercartilaginous incision. And the blade of the saw is to be carefully placed against the side of the hump, as you can see in this image over here. And we'll feel the position properly with the help of our left hand through the skin. Then you will be cutting the hump using the tip of the saw first, and we'll continue to do that diagonally. We'll move our saw diagonally. Or alternatively, you can even use an osteotome over here. We can use a Macintosh osteotome or a Gillies osteotome. Usually, osteotome has some advantages like the direction of the cut can be altered without you removing the instrument. The movements of the osteotome is much more controlled easily, and you can also even use it to remove bone from the nasofrontal angle. So now basically you have used the osteotome or the saw to remove the bony hump from there. So now that you have incised out the hump completely, we will be introducing a straight hemostat over here, and we will grasp the hump that we have cut out over here, which will first push it up and then we will slowly deliver it out. Now, as we deliver it out, usually the hump that we have removed, the upper part of the hump will form the cartilaginous portion, and the lower part of the hump will be forming the bony portion. Now, cartilaginous portion, usually what cartilage is seen over here? The cartilaginous portion usually includes the upper lateral cartilage and a part of the septal cartilage. Whereas the bony hump that you just reduced or removed will contain portion from the nasal bone and the vertical plate of the ethmoid. So this is what you are removing. So after you have cut out the hump, we will introduce a straight hemostat scissors, and we'll grab the hump and we will push it up and then slowly deliver it out. Then we are going to check for any kind of irregularity of the over the bony dorsum. If there is any irregularities along the midline or on the sides after removing the hump, we will smoothen it out with the help of a rasp. And then after we have done all of this, we'll assess the dorsum again using the help of a retractor, and we'll see if there is any irregularities at all present. So that's about our hump removal. So what have we done here? First of all, we spoke about the different types of hump, and it can be a bony part, it can involve the cartilaginous part, or it can involve both of it. So once you have done the assessment of hump removal, which is usually above an imaginary line, which is passing through the tip projection and the nasofrontal angle depth. Now we have decided, so we'll mark the area with the help of gentian violet. Then first we'll remove the cartilaginous hump and then we will cut the bony hump. And after we have made all the incisions, then with the help of a straight hemostat, we are going to grab the excised portion and take it out. We will check for any irregularities on the dorsum of the hump, and then we will, if there is any irregularities, then we'll rasp the area to make it smooth. So that's about our hump removal. After hump removal, the next step is optional. If in your patient you need to perform a septoplasty, if there is a septal deviation, in that case, right after reduction of the hump, we do the septoplasty. It is important to remember that septoplasty needs to be done always before performing any lateral osteotomy, which will be our next step where we narrow the nose with the help of osteotomies. Now, the septoplasty, if you do require the septoplasty, in that case, we should have given a complete transfixian incision in the beginning. And through the transfixian incision, we are going to approach the septum. Some surgeons, they actually prefer to make it a staged procedure where they perform septoplasty and rhinoplasty separately. Septoplasty, one of the reasons, main causes here could be in case of children. If it is a case of children, usually septoplasty is done early, and we defer rhinoplasty to till about the age of 17 to 18 years. So that's about septum correction. Next, after our dorsal hump removal and septum correction has been done, we move on to our next step, which is narrowing the nose with the help of osteotomies. So our next step over here would be to narrow the nose, narrow the bony pyramid of the nose. and this we will do with the help of osteotomies. Now, osteotomies in rhinoplasty is itself a separate topic, and I will make a separate video on this. You can check it out over there for more details. But here we're going to just talk about just a base of what osteotomy is and what are the different types of osteotomy that we are going to give. And what is the reason why we are giving osteotomy? So first of all is once you have removed the dorsal hump, after removing of the dorsal hump or even lowering the dorsal line, what happens is the dorsum of the nose, it ends up being flat and wide, resulting in what is known as a open roof deformity. So now you have basically have an open roof deformity in the dorsal area. What you need to do here before you perform your osteotomy is, if you need to excise any excess width and bulk of upper lateral cartilage to reduce the bulk of the upper cartilaginous wall, you do that. Excessive fat and connective tissue from outer surface is removed, and scrolls are also excised if required. Then coming to osteotomy, osteotomy is basically these incisions that you are going to be making in the bone, and we are going to make some reductions in the bone. So we have three types of osteotomy that we usually do here. The first one is known as lateral osteotomy. Now let's look at what is lateral osteotomy. Here in lateral osteotomy, we make a cut along the side wall of the nasal bone. So if we look at the incision, this incision over here, this dotted line that we are seeing, this is what a lateral osteotomy cut will look like. So this incision is given along the side wall, cut is given along the side wall of the nasal bone, running from the level of the piriform aperture upwards. It is usually upwards till the level over here. And the purpose over here of giving the lateral osteotomy cut is that we are freeing up the nasal bone so that we can push the nasal bone inwards and narrow the nasal cavity as much as we require it to do. So depending upon the extent of narrowing that we require, we will be giving the lateral osteotomy cut at that region. So lateral osteotomy cut is this cut given along the side wall of the nasal bone. Purpose being to reduce the width of the nose in this region. Now, a general rule over here is that with every lateral osteotomy, since we are narrowing the nose, we end up narrowing the airway to some extent, definitely. And that is the first type of osteotomy. Our second type over here is the medial osteotomy. A medial osteotomy, as you can see in the image here, this is our medial osteotomy. Medial osteotomy is where we are giving a cut close to the midline of the nasal dorsum, and we are separating out both the nasal bones from each other so that they can be moved independently. This is what a medial osteotomy cut would look like. And this is only used in cases of very significant deviation. And our third type is the transverse osteotomy. If you look here, this is a transverse osteotomy cut. As the name itself suggests, the cut that we are making over here is a horizontal cut. So this is a horizontal cut made over here across the top of the nasal bone. And transverse osteotomy will act as your upper limit of the bone movement. Thus, with the help of all these three osteotomies, we have completed the mobilization that we wanted of the nasal bones over here. So now that you have given the lateral osteotomy cut, the medial osteotomy cut, as well as the transverse osteotomy cut, now what we will be doing is we have to move the bones. Before we do that, I'll just show you over here. This is an image where you can see this is where the lateral osteotomy cut lies, and this is where the medial osteotomy cut lies. And when you're performing the medial osteotomy, this is what it looks like. And then from the medial osteotomy, we rotate our osteotome laterally to give the transverse osteotomy. So now that we have given all our osteotomies, the three osteotomy cuts have been made. Now we have to move the lateral bony wall they have to be moved in, as the nasal bones and the frontal process of the maxilla will be moved inward with the help of the thumb and the fingers of the operator. So this is our nasal dorsum over here. With the help of the thumb and other fingers in the operator, we will be moving the lateral wall in. So the bones carry the upper lateral cartilages medially along with them into a proper position. So we have basically, what we have done is we have done a medial shift of the lateral wall by gently infracturing the bony segments. So now we have mobilized the bony lateral wall and we are placing and adjusting it into a new position. After we have done that, we have to evaluate the bridge of the nose again by inspecting and palpating it and check for any bony irregularities. If there is any irregularity, in that case we rasp it or resect the portion out, and then with the help of a gauge piece we steady up the nasal wall and get the osteotomy section done. So this is about our next step, which was narrowing the nose with the help of osteotomies, where we gave 3 different types of cuts. We gave a lateral osteotomy cut, we gave a medial osteotomy cut and a transverse osteotomy cut, and basically mobilized this whole nasal bone region, and then we medialized the lateral wall of the nose. So this is our step of narrowing the nose. After we have done that, our next step would be to shorten the nose. What do we do here? Now, before you shorten the nose, there are some factors that you have to assess. These factors are, first of all, we look at the nasolabial angle. This is the nasolabial angle over here. Then we will look at the relative length of the nose. We will also look at the relation of the columella in relation to the level of the nostril border. How much of columellar show is there? To know more about columellar show, you can refer to my surgical anatomy video where I speak about it. And lastly, we'll also look at the septolabial webbing, which is this region basically, which can result as a result of prominent or excessively large nasal spine. So these are 4 factors that we will assess before we decide to shorten the nose. Now, shortening the nose itself, like the whole structure of the face is also very important to look here. Even the relation of the chin with the nose. If the chin is very small, it is receding, then the shortening of the nose should be very minimal. In case of a long face also, the shortening should be very minimum compared to a broad face. Now, coming to shortening of the nose, we can actually divide it into 2 steps. We can achieve it either by shortening the lateral wall, or we can achieve it by shortening the septum. These are the 2 ways to achieve shortening of the nose. How do we shorten the lateral wall? This is done by rotating the lower lateral cartilage over the upper lateral cartilage. And in an excessively long nose, what we do is the caudal part of the upper lateral and the cephalic part of the caudal part, if this is the upper lateral, this is the lower lateral, the caudal part of the upper lateral cartilage and the cephalic part of the lower lateral cartilage, they are excised in addition to the rotation of the cartilage. And if too much, again, as I had mentioned before, if you end up removing too much of the upper lateral cartilage, the nose will appear very pinched appearance. So that is how we are going to shorten the lateral wall. One is by rotation of the lower lateral cartilage over the upper lateral cartilage, and second is by doing an excision of both the cartilages in addition to the rotation. Second is shortening the septum. Now, how do we shorten the septum? Here, we are going to look at the caudal part of the septum, that is the edge of the septum, and we are going to excise a little strip from it. So, there can be 2 types of excision over here. One is you can either remove a rectangular strip of cartilage from the caudal end. In that case, what happens is the entire columella gets elevated. And this ends up shortening the entire nose and lengthens the upper lip without changing the nasolabial angle at all. Whereas the second way to do this would be to remove a triangular piece of cartilage, as you can see over here. The triangular wedge would be excised where the base will lie anteriorly and the apex of the cartilage would be pointing towards the nasal sign. When you remove a triangular piece of cartilage, the tip gets tilted up and the nasolabial angle also opens up. So this is how we perform shortening of the septum by excising a part of the caudal part of the septal cartilage. Now it is important to remember that we are trying to get a desired nasolabial angle over here. And nasolabial angle, usually we try to get 90 degree in men and about 100 degree in case of women. So we have to excise as much required to get this angle. After you have excised the cartilage, then we remove any excessive mucosa that is attached at this region, and thus our shortening of the nose is done. So we have shortened the nose by two ways. One is by shortening the lateral wall and second is by shortening the septum. In lateral wall, we worked on the upper lateral cartilage and the lower lateral cartilage where we did rotation and if required we even did excision of the cartilages. So that's what we do in terms of shortening of the nose. Coming to our next step, which is correction of the septolabial webbing and lengthening of the upper lip. So if this is the nose and this is the upper lip, this region that you see in between the columella or the base of the nose and the lip is the septolabial region. So the complete transfixion incision, the rotation of the tip upwards and dissection of part of the enlarged anterior nasal spine and dissection of attachments of the lip to the maxilla, all of these things, they can actually end up altering the upper lip to some extent and lead to lengthening of this region. So if we see webbing at the septolabial region, it can be either due to a prominent anterior nasal spine, or it can also be because of enlargement of the lower and inferior part of the cartilaginous septum or both. If this is happening, the connective tissue covering the nasal spine is excised and excessive hypertrophy of the nasal spine is resected either with the help of an osteotome or a bone ring. And then we place a suture between the base of the columella as well as the septum, causing pulling of tissue over the nasal spine. This will apparently increase the length of the upper lip. If the upper lip is very short, in that case, dissection of soft tissues subperiosteally through the base of transfixion incision, especially along the attachments of upper lip and gingiva, will cause relaxation and increase in the length of the upper lip. So if there is any webbing in the septolabial region, we are basically correcting it and we are lengthening the upper lip. So that's about this step. Next step would be, lastly, is the remodeling of the tip. Now you have narrowed the nose, you have shortened the nose. If there is some minor tip deformities, that may become prominent now. So you have to look at the best way to look at the tip and judge the height and width of the tip would be by seeing it from the basal view, which is observing the nose from the bottom. If it needs to be reduced, you remodel it by cutting down the height, the width, the length of the lower lateral cartilages. Some surgeons even recommend cutting the tip before narrowing the nose and hump removal as a routine procedure. So that's about our last step before you close down all the incisions. So now we are moving to closure of the incision. So we had given the transfixion incision, if you remember. So before closing the incision, we have to, for the one last time, we'll be inspecting and palpating the whole of the reshaped parts of the nose and see if there is any irregularities or if anything needs to be trimmed, rasped or something, and if any further refinement is required. Once you have done that and you're sure that no further changes need to be made, then you take 2 square gauge pieces and with the help of that you squeeze any blood or blood clots that is there under the soft tissue by applying pressure. How will you do this? You will hold one gauge piece in your right hand against the nostril while you're supporting the tip. So this is for supporting. And with your left hand, you'll hold the second gauge piece and you'll squeeze and compress the skin of the dorsum. And as you move from above downwards, that's how you squeeze out all the blood and the blood clot that has accumulated under the soft tissues. Once that is done, the columella is anchored to the caudal edge of the septum with the help of chromic catgut or 6 sutures. And septal mucosa with columellar skin is sutured, and 2 to 3 sutures on each side is put. Marginal incisions, if it has been given for tip surgery, those are also approximated with 40 chromic catgut sutures. And lastly, the intercartilaginous incisions that you had given, we are not going to be closing that, as that open wound will help you in with the drainage of any blood that remains, and it will also prevent any web formation in the valvular area. So that's how you will close all the incisions. Now, the only incision that you do not close is the intercartilaginous incision. Now that you have closed the incisions, last is the dressing of the nose. So first of all is packing. So the nasal cavities you'll have to be packing as you do for any nasal surgeries, with a Vaseline or paraffin lubricated ribbon gauze. We'll do a loose packing. We should not be doing too tight packing, because that can cause a splaying out of the bony segments of mobilized lateral walls. So we'll avoid any kind of tight packing. And the purpose of the packing being, first of all, it will help you in reapproximating the unsutured incisions, and it will also prevent the development of a septal hematoma. And depth of the packing, how deep will you go to pack, will be decided based on whether septoplasty was part of the procedure or not. If you have not done septoplasty, in that case, just a light packing, just little beyond the vestibule, is sufficient enough. Next thing to know is, when do you remove the pack? So pack removal happens after 48 hours in case you have not done a septoplasty, but if you have done a septorhinoplasty, in that case you remove it after 72 hours. So this is about packing of the nose. Next is, how do we fix the skin? So first we will be cleaning the skin, and any collection of blood is taken out. Now the purpose of the fixing of the skin over here, which is basically what we call as taping. There's 4 purpose of taping over here. First of all is that it is important for the skin to redrape and fix effectively. Second is, it will prevent a hematoma formation development. Third is, it will reduce dead space. And fourth is, the taping will prevent any malpositioning and asymmetry of the reshaped alar cartilage. So that is why we need to perform taping properly. Now, how do we do this? First of all, if we look at the first image here, the dorsum of the nose is taped with about a half or a 1 centimeter broad adhesive paper tape or a micropore tape. So you put a longitudinal strip, as you can see over here. It is applied around the lobule like this at the upper part of the columella and extending halfway along the lateral nasal walls. And you will pinch it at the tip of it to splint the narrowed nasal tip and hold the columella up. So this is our first tape. Next, we will apply several layers of tape. If you look at this, ultimately it should look like this. We will be applying multiple layers of tape across the dorsum of the nose, right from starting from the supratip right up to the level of the nasion. And these strips should be overlapping each other, and you should definitely try to avoid any wrinkling of the skin underneath the tapes. So this is how we are going to tape and fix the skin. And we have also talked about what is the reason why we are taping the skin. Lastly is splint, applying the splint. Now again, splinting also has different purposes here. The aim is being, first of all, it will help in preventing the development of any swelling. Second is, it will maintain the position of the mobilized bones. Third is, it prevents the displacement of bones accidentally when the patient is in sleeping position. So sometimes you may not be aware of how you're sleeping. So the splint will make sure that the bones do not get displaced accidentally. And lastly, it will also provide protection from any minor injuries. So that is why we need to apply a nasal splint. Now, what are the materials usually used? The best material to use in this case is plaster of Paris. Now, plaster of Paris sets in position very effectively, and when swelling occurs, plaster cast does not lift off easily. So that is why this is a preferred material. But there are other materials also that you can use, like dental composition material. This is also good because it sets off very easily, but it does have a disadvantage that in summers, because of a lot of heat, it can end up softening up and lift off due to soft tissue swelling. And third, you can even use aluminum foil splints, but the best material to use is still plaster of Paris. Now, what do we do here? Plaster of Paris, we use a 6-layered plaster of Paris bandage and we soak it in tepid water and we apply on the nose till it becomes hard and set. The tip has to be fixed with separate pieces of plaster bandage and we fix the plaster splint with the help of zinc oxide or any micropore adhesive tapes. You can use the splint with or without a forehead extension depending on your need. Some things to keep in mind while you are putting the splint on the patient is that it should not extend lateral to the site of the lateral osteotomy. Why so? Because if that happens, the extension will end up transmitting all the movements of the face to the splint. That is, when you're smiling or laughing or chewing or any movement of the face, all of those movements will get transmitted via the splint into via the splint over to the operated area. So that's why you should avoid splinting extending lateral to the lateral osteotomy site. So you have to be very careful about that. When do you remove the splint? The splint is usually kept about 7 to 10 days, and sometime around that you remove the splint. If the post-operative swelling is very excessive, then the splint should be kept for at least 10 days. And when marked post-operative swelling develops and the splint becomes very loose, and as the swelling regresses, the loose splint can be replaced by another splint. So that's all about splinting. So that's about the different steps of the procedure that we have learned today. If we had to revise once again, we have our opening incisions first, then we mobilize the skin, elevate the periosteum, manage the upper lateral cartilage, then we perform hump removal, very important over here. Hump removal first, then septoplasty, then osteotomy. Then we shorten the nose, correct the septolabial webbing, any tip remodeling, and then we close the incisions and pack the nose, fix the skin, with the help of tapes and splint the nose. So that completes our rhinoplasty procedure. This is a very important long question that you are often asked in your theory exams and you should be knowing about. Lastly, let's in short discuss what are the advantages and disadvantages of following this closed approach. Advantages being, as we learned, there is no external scars because you have not given any external incisions. Second is there is less post-operative edema, shorter operative time, patient recovers faster, and the nasal support structures are well maintained in this in the closed approach, and there is a reduced risk of columellar complications because we are not giving any transcolumellar incision like we do in open rhinoplasty. Lastly, coming to disadvantages, the surgical exposure is very limited in in closed rhinoplasty. That is why the indications are very limited. And this is also technically more demanding. This becomes very difficult in case of complex tip surgeries or severe nasal deformities, and it is also much more difficult to place and adjust grafts in a closed approach. There is also a reduced accuracy in symmetry assessment, and if there is a revision case, then doing a closed rhinoplasty is much more difficult. In that case, external rhinoplasty is preferred. And lastly, because this is a closed procedure, this has very limited teaching value in case you want to teach students about the steps of the surgery. So that's all about closed rhinoplasty or endonasal rhinoplasty. If you have any doubt regarding this, please note them down in the comment section and I'll get back to you. Thank you.